into Instagram live Q&A with JJ. Sorry, I've already typed this in once, but I don't know what I did. If I pressed the wrong button with JJ Staiano, that's me, by the way. Plastic surgeon. Add title. Right there. So good evening. It's 7 o'clock ish, and Instagram's on. Instagram's a bit high, is it? Facebook's on, and they're just telling my followers that I've started a live video. Okay, so should we wait for the followers to join? There's my blanket. I'm going to put my blanket on because I know it's hot, but you know, I don't know where my slippers are, so feet are a bit cold. Anyway, good evening, Tasha. Hugs, Gina in the house. Tracy's in the house. Big up yourself, Tracy. Smiling emoji. Right, what we got? Hope you've had a good week. I have had a good week. Thank you, Tracy. I'll tell you what I've been doing. Hello? Yeah, no, I'm on Facebook Live. Is that my new phone? Can't get it to work, though. Birthday present. Old school. I've been in Liverpool, Tracy. I've been in Liverpool doing some operating. That's where I'm doing most of my operating at the current time. And just got back. Nice, traffic's good. So that's been good. So Amy Summerbonnie is here. Hello, Amy. And Sophie is here too. Hello, Sophie. Good evening, everyone. Jackie Crimes is my staunch supporter on Instagram. So what's all the laughing? Right, good evening. My phone. Yeah, no, I'm on the Facebook Live. Yeah, I can't talk now. Okay, thank you. Bye. Right, good. Okay. Yeah, and Instagram. Yeah, not just Facebook. Right. Yeah, it looks good. It's got the old you know, a bit too quick. Recoil's a bit too quick. You know? I mean, when they made phones like that, remember they phones like that, yeah? Why was it 999? Can anyone answer me that? Because 999 would take ages. 9. I mean, it should be 111, surely, for those old phones. I mean, at the moment, it doesn't matter. Obviously, 999, 111, and you just press the button. But when they had old phones, why was it 999? Because that the ring, the circular thing had to recoil back. Anyone answer that? Tracy, Sophie, phone and blanket. Yeah, you weren't supposed to see the blanket. Did you see? You saw the blanket. That's a bit embarrassing, but anyway. Oh, anyway, that's what it. You know, that's what it is. What's your number? My number, Tracy, is 0121 454 3680. Call me. But this phone doesn't work because I can't make it work. I think it's something to do because they fiddle about with the phone sockets when they put the internet in. And I think they've done something to the extension sockets. So it all relies on one phone that's plugged in. And, you know, the other ones are all on extensions. But I would like a normal phone, and I think it's good to have a backup phone, but I think they've done something to extension sockets. What do you do if you've got a problem that you need phone extension sockets looked at? You know, I mean, is there a phone person like there's a plumber? You know, you don't necessarily want to go BT or something, but are there people that do phones that aren't sort of BT or whatever? You know, you've got plumbers and you've got electricians, but do you have phone people? Or would that be an electrician? Would they know their phones? Anyway, enough of my problems. Let's do this because we all know let's not beat around the bush. We all know what we're here for, okay? On the podcast, I'm probably going to cut out all of that and just go straight into this bit now. So pause. So take one. So if you clap, you get a spike in the... Yeah, that's why they have the clapper board. Since I've been doing video, I've realised that sharp spike, and now you cut everything before that. I'll have to cut this bit as well. So before I start the open reach. Yeah, but that's the same as BT, isn't it? It's sort of still Like, I mean, can you phone OpenReach and say, hi, I've got an extension. I don't think my extension thing's working. Can you? I don't think you can phone. Anyway, if you know whether you can do that or not, please let me know. And also, if you know why it's 999 when it takes so long for the number to recoil, very interested to know those answers to those questions. But those are my questions to you. But in return, I'm going to answer your questions to me. So we'll start it. Right, there we go. So cut it, everything before there. So good evening, Facebook Live and Instagram Live people. Finstagram. Instabook Live. Instagram. No, Instagram's better. Facegram. Anyway, Instagram and Facebook. It's just because I've been doing Facebook longer. I tend to say Facebook, and I feel bad because Instagram is very active. Anyway, the question that we're doing now. So, first question. Okay. First question is, good evening. First question is, you have said that polyurethane implants move less post-procedure, which places the onus on the surgeon to place them correctly. How do you do that? Good question there. Thank you for that question. Good evening, Joe Mollies of Eoli as well. And hi, Liz, and hi, Rosie, and hi, OpenReach Tracy. So, yeah, so this is my patient, I'm assuming, because I think I said this to a patient the other day. So polyurethane implants are basically more difficult to use than silicone implants, and there is a bit of a learning curve with polyurethane foam implants because polyurethane implants behave slightly differently to silicone implants. Now, to be honest, you have to make sure you place them both correctly, whether you're using polyurethane or silicone implants. The difference between them is that you're absolutely right, polyurethane implants move less because the scar tissue grows into them. So the way you make the pocket slightly differently, I'm not sure if this is really relevant for members of the public, to be honest. Anyway, I'll say it. Anyway. So when you do a breast augmentation, you have to make a pocket, you have to make a space to put the implant in, whether it be in front or behind the muscle. You make a space, and you make a bigger space for polyurethane than you would with a silicone implant. So with a silicone implant, you talk about a hand in glove type fit. You make a space the size of the implant to put the implant in. You don't want to make it too big because the implant might move about. You don't want to make it too small because the implant might wrinkle up and crease. So with a polyurethane implant, you make a much bigger pocket. You make a wider pocket because that polyurethane is like there's a lot of sort of there's a lot of resistance. I don't know if you can imagine it when you're going in with a polyurethane implant. It's like they're furry implants, so you don't want it rucking up. I haven't got one, but you could ruck up if you made a tight space. So you have to make a very wide space, and you have to make sure it's sitting flat. And the reason you can make a wide space, a space bigger than the size of the implant, is that, as you say, you can place it and it stays where you place it. Whereas a silicone implant, if you made the space too wide or too high or too low, the implant would fall into that space. You have to be careful with both is the answer, and you have to make sure you place both correctly. And there is there's a learning curve with polyurethane foam implants if you haven't used them much. But the point I think I was making with this is that it's really important to choose your surgeon rather than the implant. I think that's more the point I was making, because a lot of people get a lot of angst over what implant they should have, which I don't think is necessarily wrong, because I think it's a very important decision what implant you should have. But they seem to spend a disproportionate amount of time worrying about the implant rather than the surgeon. They'll be like, oh yeah, I don't know what my surgeon's name was, or I don't know who he was, didn't really see him, saw him for 5 minutes or her for 5 minutes, and then I saw one surgeon and had surgery and there was another surgeon and all this sort of thing. And I'm like, it's really more important to choose your surgeon than your implant, I would say. Within certain remits, it doesn't matter hugely I'm playing with my crystals there, what implant you have. based on the base width is really critical for me, and that's the first thing that I go on. And so there's usually a couple of implants you can choose from, which people do have a lot of worry about which one they should choose. And I always say to them, look, between one or two implants, particularly within the same profile, the difference isn't going to be significant. But if you get them placed wrong, too high, too wide, one up, one down, whatever, then you're not going to be happy. So I think that is the point really about the placement. But how do you place the implants correctly is how the surgery and how you do it. And the main thing that I normally want to talk to other people who are sort of thinking about using polyurethane implants is to put them low. You have to put them much lower than you would, for instance, a silicone implant, because a silicone implant will drop into the pocket. Silicone implants start high and drop. They do sort of drop into the pocket. Polyurethane implants don't drop. They sort of stay pretty much where you put them. So you've got to put them in low. Because they'll stay there, and sometimes it can look quite low when you do the surgery, but particularly if you're used to silicone, but it's just something that you've got to get used to if you're a surgeon using them. Having said that, they do start swollen and then settle, but they don't particularly move. They don't particularly drop in the same way that silicone implants do. Let's answer that question. Got a question here that says some surgeons recommend the use of muscle relaxants after augmentation, assume when under the muscle. Is this your policy too? Could the patient who's asked that question please elaborate on that, if they're out there? Surgeons recommend the use of muscle relaxants after augmentation. What does that mean? What, like diazepam and things like that after surgery? I've never heard of that. I would not do that. I mean, in principle, I guess they're saying the muscle contracting is going to hurt. I'm assuming that's the rationale behind it. It would also, but it's nothing I've ever heard of, to be honest with you. And I don't. It's not my policy to give muscle relaxants after a submuscular augmentation or any augmentation. And it's no. I mean, muscle. I'm assuming you're talking about benzodiazepines, like diazepam and things like that, which are sort of a bit sedative and can make you feel a bit drowsy, which might be good after surgery. Might be good to have a sort of relax you, but I wouldn't do anything particularly to relax the muscle. Personally, personal preference. But I've not heard of that. Has anyone heard of that? Has anyone heard of muscle relaxants being used after breast augmentation? Anyone? No? What should we be monitoring post-augmentation, i.e. what's not normal following surgery and cause for a call-in? Oh, good. We got a question on Facebook. All right, Adele, hold fast, Adele. I'll just do this one, then I'll be with you. Post-augmentation. I tell you what, it's interesting this, because I mean we give you a post-op instruction sheet with what to expect, and broadly speaking, I think probably the biggest problems you're going to get, or the biggest things you're going to be worried about in the immediate post-operative period, which is the first 24 hours or so, is going to be hematoma. Hematoma is bleeding inside the pocket. It means the breast gets very big, tense, and swollen. And then the other thing you're going to get in the early post-operative period, in the first week, I would say, is infection. Infection means it gets red, angry, swollen, painful, tender. With both of these things, those are looking for. You're looking for swelling from a hematoma and infection, red, angry, swollen, tender. You might say, I've got a dressing on, I can't really see if the wound is red and things like that. With both of these things, I think the easiest thing that I find is helpful to say to people is what you're looking for is a unilateral problem. So if your problem is on both sides, then it's less likely to be worrying. So I say, look out if they're tense, swollen, painful, red, hot, all these things. Tender, you might say, oh my God, you might get home and think, oh my God, they're tender, red, hot, swollen. I've got an infection, or I've got a hematoma, or I've got this or that. But I'd be like, if I say, right, is it one or both? Like when I see you post-op, I'm always like, are you in pain? Oh God, yeah, it's really uncomfortable. Or no, people don't say that afterwards. They say, no, I'm all right, a little bit of discomfort. And I always say one or both. And if you say both, I'm relaxed a bit. I'm like, good. If you say it's the right one that's really causing me bother, I'll be like, oh right, okay, let's have a look then. So it's unilateral. It's going to be unilateral. It's going to be one side. So if you get a disproportionate problem on one side over the other, that would be more of a concern than if they're both a problem, because they're often quite red and quite tense and quite hot and quite swollen and quite painful. They could be all those things, which are all signs of infection, but they're also signs of surgery and inflammation and, trauma that you've had. So if it's both sides, I'd be less worried, bottom line. And also bottom line, if you're worried, just ask us, just give us a ring and ask us. But yeah, mainly a one-sided thing, I would say is a not normal thing post augmentation. We'd have a low threshold to intervene. So just get on the blower and give us a ring or email or whatever you want. An email with a photo, that's quite useful, taking a photo and emailing it. Because often you're like, oh, it's really tense and swollen and hot and painful, and you say, send us a photo. And you're like, well, you can't really see it on a photo. And you'd be like, well, if you can't really see it on a photo, it's unlikely to be that swollen. A hematoma is like pretty obvious usually. It's like twice the size of the other side. So sending a photo is good. Adele, what you got? If the implant was previously over the muscle, when replacing implants going to go under the muscle, what would be the implication of this? Yeah, that's a reasonable thing, Adele, and the usual indication, rather than implication, I'll talk about the implication, but the indication would be rippling. Would be the sort of normal thing. If you've got visible rippling, maybe you've lost weight or what have you, and you can see the ripples of the implant, then you think, crikey, how am I going to cover that? So moving it from on top of the muscle to an under the muscle plane would be possible. And the other way, Adele, you can move it from an under the muscle plane to an on top of the muscle plane. So you can basically change planes is a reasonable thing to do. You have to be a bit careful, and you have to close down the original plane so that it doesn't flip back into that plane. So the implications of this is just that the surgery take a little bit longer, but it's fine. And sometimes, particularly if you're changing type of implant, for instance, if you're going from a silicone to a polyurethane implant, the coating, it's nice to put it in a fresh pocket. So that either means doing a complete capsulectomy, a total capsulectomy, or changing plane would also be a way of putting it in a fresh pocket so that tissue can sort of grow into the polyurethane implant. So yeah, that's a reasonable thing to do, changing plane. Adele. Liz gets double brownie points because Liz is hashtag askJJ. So that is what I'm talking about. They're talking out there. They're starting to talk out there about that hashtag. We're getting noticed, guys. Things are going to start happening. That hashtag is getting used. You know what I'm saying? Hashtag askJJ. How would the surgeon decide on what type of TT I need? Would I be able to choose? Good question. Like it. So, well, bottom line is, to a degree, Liz, you would obviously have an input on it. So to a degree, you'd be able to choose. So the fact of the matter is, not everybody can have every type of tummy tuck. So the classic example being a full tummy tuck. So a full tummy tuck takes all the tissue from your pubic area, from just above your pubic hair, if you have a cesarean scar, from where that cesarean scar is, to above your belly button. So all that tissue is removed with a full tummy tuck. And the tissue that goes from your belly button up to your xiphisternum, up to your rib cage, is then pulled down. So if you haven't got much tissue, if you haven't got much laxity, the paradox, if you haven't got much spare tissue, we're not going to be able to get that tissue from above the belly button all the way down into your pubic area, pubic hairline sort of thing. So So you might not be able, we might not be able to do a full tummy tuck, so in which case you might be only a candidate for a mini tummy tuck or no tummy tuck. If you were a candidate for a full tummy tuck, then really the other types of tummy tuck, so we're probably talking fleur-de-lis and circumferential 360-degree tummy tuck. The fleur-de-lis and the 360 are only really for people who've had massive weight loss. So if you need a significant skin excess to justify the extra risk, complications, and scarring associated with those types of tummy tuck. So if you've got loads of skin laxity, if you've lost a lot of weight and you've got a lot of skin laxity and you have got laxity in the side to side as well as the up down direction, then a fleur-de-lis, or if you've got a lot on the sides, then a 360-degree circumferential tummy tuck might be an option. So if they're an option, then you can decide. You can decide whether you have a fleur-de-lis or a 360 or a full tummy tuck. And what I say to people is that, you can have nothing. You don't need any tummy. No one needs a tummy tuck. You can just carry on with your life without a tummy tuck. If you're a candidate for the bigger ones, and let's say not many people are, it's only significant weight loss patients. But if you're a significant weight loss patient and you're a candidate for all of them, then I would say to you, look, the more scarring, the more skin's removed, the tighter it is, but the more visible the scarring and the more the increased complications, costs, risks, etc. So it's a bit of a balance there. So it needs a discussion, and you would definitely have something to say on that. So yes is the answer. You would be able to ultimately decide what you have, but you might be precluded from some types of tummy tuck depending on how much skin laxity you've got and where your skin laxity is. So you'd have to be guided by the surgeon, but you would have to be involved in the decision, sort of thing, But good question, Liz. And with a hashtag askJJ. Guys, that's going to be a hard one to beat. I'll be honest. I'm just going to put it up on screen. Sorry, Instagram. I can't put the questions up on screen. But that, my friends, is a hard one to beat. Hashtag askJJ. How would the surgeon decide on what type of TT I need? Would I be able to choose? That, my friends, is how it's done. Liz, go and get yourself, a hot drink because you deserve it. Right. That is a good question by Liz. Right. What we got? What's going on? Instagram's going. This is what we need. Interaction, Look at this. Evolve Massage. Great to know how well you look after your post-op clients. Impressed. That's what I'm talking about. So what it's all about, Evolve. It's all about the aftercare. It is all about, I've always said that, and I always do my best to look after people. Dr. Katie K. Hashtag askJJ on Instagram. That's what we're talking about. If 3 months post-op breasts are still uneven, what can be done? Right. Well, you obviously heard me talk because 3 months is sort of minimum, KTK, minimum for thinking about stuff. And at 3 months, so at 3 months, things start to settle. Important use of the English language, start. So they only really start to settle at 3 months. So at 3 months, they start to settle. So I would have a judgment on that one at 3 months. And Katie, I would say it would depend on how bad it is. So if they are way off and you think this ain't coming back, whoops, or I don't know, something really bad, I would maybe think about revision at that stage. But I would prefer, and particularly if things are getting better, you've got to be true to yourself. And a lot of people try and sort of push for a revision, like, oh, they're not right and I'm really unhappy. And be true to yourself. If they are settling a bit, in your heart of hearts, if things are getting a bit better, I'd be like, can we just leave it a bit? Can we just see how much they settle? Because you'd be surprised at how things settle in the first year, 18 months, Now, it's a balance because you don't want to have an unhappy patient for 18 months who's going telling all their friends that they're all wonky and this guy's rubbish before you fix it. So you want to fix it as soon as possible if it's going to need to be fixed surgically. But a lot of things will settle. You would be absolutely surprised at how some, wonkiness or unevenness will settle. So my preference would be to leave it as long as possible, ideally a year, to be honest with you, but you have to get people to a year. If you say that right off the bat, if you say that at 6 weeks, oh yeah, they're a bit uneven, and if they're still like that a year, I'll think about doing something. They'll be like, what the heck, you're not going to leave me for a year. So you have to keep patients involved and keep looking at them and examining them and seeing them and reassuring them that you will do something about it. And as I say, if it is, you know, pretty way off, I would think of doing something sooner. But what I would say is, the longer you leave it, the better, because things might get better. And the way I phrase it with people is, look, I don't know whether you're going to need a revision or not. You might need a revision. But what I do know is things will change over the coming months. And so, you know, this is not your final result. So it would be wrong to do a revision if this is not your final result and you really want to wait as long as possible. And yeah, and as I say, 3 months is when I say things start to settle. And I, you know, if it's like a big dog ear or something like that, and it's like really big, I'll be like, you know, and they're really annoyed by it as well. If they're not annoyed by it, then I'll be like, well, it might get a bit better, and then I might be able to make a smaller scar if I did revise it, sort of thing. So it's a joint thing with the patients, but you have to really try and keep people on board, because it can be distressing if things are uneven. And I think for me, most of it is saying to people, don't worry, I will fix it if it's still uneven at 6 months, 12 months, whatever. But if it's get better, can we just leave it and see where we're going to get to? Because A, I might not need to do anything. And B, if I do need to do something, I might need to do less if I do it later. And it can be difficult, you know, bitter pill to swallow, because obviously when you have your revision, if you do have a revision, that's going to need to settle. You know, you have a fresh scar and they'll probably be uneven again and you have to leave it settle. So it's like, I'm not going to wait a year and then you operate on me and I have to wait another year for that to settle. So again, it's all about, which is just what it is. So it's all about talking to patients and trying to get them on side, and leaving it as long as possible. In my view, is what I would do, and working closely with them. That's my advice on that one. Anna, what you got? What pain relief typically is required after a mastopexy? I tell you, Anna, ibuprofen and paracetamol. I know what you're going to say. What? That's headache tablets. Come on. They're good painkillers. Trust me on this. Usually, the pain isn't too bad. Usually, now someone's going to come on and say, I had a mastopexy and it's really bad. But usually, it's just tight. Feels tight, feels uncomfortable, feels swollen, feels weird, all these things. But pain, usually, if any mastopexy people are out there, you know, correct me if I'm wrong, but usually it just feels tight, feels uncomfortable, and pain hopefully is not too much of an issue. So I like simple painkillers, stuff you got in your cupboard, ibuprofen and paracetamol. Having said that, if you do have pain, we will give you stronger painkillers from the opiate group. It's a group of painkillers in the opiate group, which the normal one is codeine phosphate. There's also things like cocodamol and coproxamol and stuff, which are like codeine type drugs, with paracetamol, tramadol, and morphine, obviously, and things like that. So those are sort of opiate types. So codeine being the normal one, if you like. And sometimes we do sort of give you codeine if you're in pain and it's not controlled, which is fine because they're really good painkillers. Don't get me wrong, but they can make you feel sick. They can make you feel dizzy. They can make you constipated. So and the constipation can be worse than the pain. So I would say be careful with the codeine type ones. If in my book, I would say, look, I would be a bit. If you're in pain, by all means take them. But if you're not in pain, I would go with, or if your pain's not too bad, I would go with ibuprofen and paracetamol. But we will give you more if you need. Hannah Resada. Hi, what is considered significant weight loss? Well, it depends on how your body reacts to it. Everyone reacts differently, but I would say significant weight loss. I'm going to say 5 stone. I would consider significant. So I think, you're looking at the 5 stone plus is your fleur-de-lis circumferential realm. But even then, some people can have 5 stone weight loss and not be too bad. Some people can have 3 stone and be like have a lot of loose skin. So it is depend on the person. But if you're asking for a number, Hannah, I'm going to give you one. 5 stone. How's that? Official Colette, hand up. Oh my God, there's a question on Instagram. We've got an officially typed. So that is exciting. Right, Holly, stand by, but I'm going to go into the official question of, do you do revision tummy tucks? Nice. Do you do revision tummy tucks? What do you mean by that? Yeah. Well, yeah. I mean, that's a funny question. Official Colette. I mean, I think most of us will do revisions. I mean, you have to do revision surgery if you're doing surgery because sometimes you have to revise. I'm assuming you mean not my own case, not my first time case. So in answer to the question, yeah, official. I had a tummy tuck and need a revision. I mean, it depends. The thing about follow-up and revisions and stuff like that is it depends on when the first one was. So if your first one was like a year ago, 5 years ago or something, then yeah. But if your first one was like a month ago, then I'd be like, hold on a minute, you get your, or within a year, say, then I'd be getting your surgeon to go for it. So that's not written in stone. That's something I just thought of now, the year thing. But yeah, in general terms, 24 weeks, that's less than a year, isn't it? Yeah. I think you're better off with your surgeon, official Colette. And also, I think you're better off going, what's 24 weeks in terms of months? Or 24 to 12, well, that's 6 months, isn't it? Yeah. I think you're better off with your surgeon. Yeah, I'm doing that emoji. Yeah. Better off with your surgeon, official Colette. It's tricky. I've got to be honest with you, official Colette. Revision surgery is difficult. I mean, it sounds what's the word? Crass, is that the word? Anyway, it just doesn't sound, it's not helpful to say, oh, it's better to do it right first time. That's really unhelpful. But, it is difficult, revision surgery. And it is much easier when you get someone who's not had surgery than when you have someone who's had something and the scar, because you're dealing with scarring and things like that. And revisions are difficult, period. And it's bad enough doing your own revisions, but doing revisions of other people is it's a funny area, official Colette. It's a funny area, and I think my advice is normally to stick with your surgeon, although I understand people can maybe think, oh, they've got me here. But anyone can have problems. Anyone can have situations where people need revisions. Doesn't necessarily mean they're a bad surgeon unless they've been treating you badly. But I do think it is best to try and work with your surgeon as much as possible. Also, official Colette, financially, often surgeons will do revisions for free if they're their own cases, because they've got a vested interest to make you happy, because they don't want people going out saying that surgeon was rubbish. So your surgeon will have a vested interest to try and make things right. Whereas you go to a new surgeon, they're going to just say, all right, well, it's loads of money, when you've already presumably spent loads of money on the surgery in the first place. So sorry, I thank you, lol. I agree it's bad not doing your own revision. He quoted a lot. Your surgeon quoted a lot, did he? The same to do the revision, did he? All right. Okay. Yeah, tricky one, official. I feel your pain, but leave. And the other thing I said earlier, I don't know if you were here, leave it as long as you can, because things might settle. You never know. I know it's 24 weeks is 6 months, isn't it? 50, yeah. Are we allowed, Tori? Allowed? Come on. Are we allowed to bring someone with us to a consultation with yourself face to face? Tori, yes, you are. When we send out, and I know why you're asking that, because if you have booked a consultation to see us, you get all these emails saying, don't come alone, come alone. We will be watching you. But we have to write that because of the COVID. And we do encourage it as well because of the COVID. Sorry, it's a dog. Visitor at this time of night. So yes, we do encourage you to come alone if you can come alone. Having said that, a lot of people want to bring a bit of moral support, don't they? So if you want to bring someone for moral support, absolutely fine. And people do bring friends, partners, spouses. Yeah. So yeah, you can, Tori. Is the bottom line. Just let us know. We write a little note saying bringing whatever. You've quite a lot to revise. Yeah, no more comments. Lol. No more comments. What does that mean? Thank you. You're welcome. No more comments from him or from me. I'll comment, official Colette. I will comment, and I'm happy to comment. And but I think revisions is you touched on a difficult point there, official Colette. You've touched on a difficult one, and I've got to be honest with you. would I say we see it a lot? We do see it, quite a bit with people who are quite recently post-op who want help, and I feel for them. But at the same time, the problem is, and I said this before, is that the money, the price that you pay, and I don't know, I'm not saying you went for price and things, but just in terms of the surgery is priced based on the whole package of the surgery and the aftercare. We don't have packages just for aftercare. So the surgery is priced for the whole lot. So it is difficult when people want some help after their surgery, because we're like, well, we don't help you after your surgery, but if you've had surgery with someone else, because anyway, maybe that's not helpful to collect, because you're asking for a vision. But yeah, right. Yeah, good luck, official collect. Good luck, and and if you want if you want to send us a photo, I can give you an opinion if you want. But as I say, always stick with your search. It'll be helpful. Feel bad. Feel like I'm being unhelpful live on air. But anyway, it is difficult. Yeah. Oh dear. Right. Hannah. Here we go. What we got? Holly Elizabeth. How long should I wait for a tummy tuck after a C-section, please? Holly, that's a good question. That's up there with Liz's question. Haven't done the hashtag. If I'm going to pull you up on anything, haven't done the hashtag, Holly. So I'm just going to pull you up on that. Hashtag askJJ is what we're getting trending. Well, the minimum, Holly, is because you have to let your body recover. So your minimum is 6 months. So, sometimes people will see at 3 months with a view to doing surgery at 6 months, but that'll be the minimum. But the other thing you've got to remember, Holly, is you've got a 6-month-old baby. So it can be tough. So I think it's a bit easier when they start walking. So maybe about a year. Now, I know that a lot of people say, well, my maternity leave runs out at a year and I want to get it done before then, which is fine. But you need to have help because, you don't really want to be lifting a baby, and it can be difficult. 6 months can be difficult. If they're a bit more mobile, it can be a bit easier, although I understand they're going to be bigger, obviously. But I would say a year is better and 6 months is the minimum. Is the answer to that question? Hannah? Paracetamol might be ibuprofen, fine. I'd rather avoid opiates. I'm a nurse, I understand. Yes, I would rather avoid opiates too. I'm with you on that one. We are singing from the same hymn sheet, Hannah, my girl. Do you mind if I call you Hannah? Anna, is that all right? Yeah? Because I just had Holly and Anna. Just Hannah. Right, what is going on? Quick, get another question up. Gloss over it. Here we go. Holly's back in. Holly, hashtag askJJ. Sorry, I'm new. First time. Holly, you didn't know about the hashtag. To be fair, nor did the rest of the world. It's something that I'm trying to do, but I'll be honest with you, it's not setting the world alight. But it's still, anyway. Don't you worry, Holly. I was only joking. I didn't really mean it. But it's fine. You can ask questions without a hashtag. But thanks for getting it in there. By the way, that's very helpful. What should we monitoring post? We've done that one. Is there a reason? Here we go. Is there a reason why there is such a variance in time for different patients that have implants? What does that mean? What is that question? I don't understand the question. Is there a reason why there is such a variance in time for different patients? Does that mean the settling, do you think? What do you think, guys? What does that question mean? Settling, does it maybe post-op settling? So there's not that much of a variance, although polyurethane settle differently to silicone, but they both, everything, the 3-month thing, I say everything. I don't know if I can get the core question. There's a spreadsheet with all the questions on, but I don't know if I can. Should have probably done that before. Let's assume it means it means the post-op time. So yeah, polyurethane implants don't really drop. Oh, here we go. Oh, it was on email, that question. So anyway, is there? I could find the email, but anyway, yeah, I'm going to say it's probably due to. So let's start again. So is there a reason why there's such a variance in time for different patients that have implants? Yes, well, the variance for patients who have different implants. Different patients or different implants? Yeah, so basically you've got silicone and you've got polyurethane. Polyurethane start a bit swollen and then settle. Silicone ones drop. So their shape looks a little bit, they look a bit higher, the silicone ones, than polyurethane ones. Having said that, if you've never had any implants, I wouldn't worry too much about it. It's not that much of a difference. The bottom line is they both start a bit up there and then they settle, should we say. And the time, there's not a huge variance in time. I normally say, normally catch up in about 6 weeks. At 6 weeks, your scar's quite red, your shape's not there. And then 3 months is sort of where things are starting to settle. The shape's starting to get a bit better. Scars starting to fade and soften. But it is 6, 12, or 18 months really for everything to properly settle. And that's for all types of implants, really. The silicone ones do feel softer than the polyurethane ones. They do feel a bit firmer and take about a year for them to soften because the scar tissue grows into the foam, whereas the scar tissue just goes around the silicone one. So there's actually more scar tissue with the polyurethane one, but it grows into the foam. And so that when it contracts in different directions. So the scar tissue around the implant is actually what the capsule is made of. So the capsule is made much more haphazard around a polyurethane implant than it is around a silicone implant. So a silicone implant feels smooth to start off, feels soft to start off with, but then over the years can start to harden. Whereas a polyurethane one feels a bit firmer because that scar tissue is growing into the foam to start off with, but then over the years stays soft. So I hope that's answered that question. I'm sorry if that's not answered it properly, but Anna, Holly, Aimie is in. Hi, I was wondering how long round about someone working at Costa would need off. Good question, Aimie. How? Oh, look at that, Aimie. What's she gone and done? She's gone and posted the same question with the hashtag askJJ. Aimie, really, I don't know what it does, Aimie. Don't worry about the I don't know why I'm telling people to do the hashtag askJJ, if I'm honest with you. Does it do anything, the hashtag? I don't know. It's an Instagram thing, isn't it? Hashtags. So don't. But thank you. I mean, we'll keep it. Let's keep it going, guys. Yeah. Hashtag askJJ. But thank you for reposting the question with a hashtag. That's very much appreciated. So Costa, how's it going, Aimie? You busy? Just doing takeouts, aren't you? Mind you, be opening soon. Will it? Couple of weeks, is it? Non-essential shops. Does that include getting? I do miss sitting in a coffee shop. I do miss that, Aimie. I'll be honest. So I would say that if are we talking breast uplift? So breast uplift, you're going to feel uncomfortable, sore, tight, all these things. 2 weeks, I'm going to say. After 2 weeks, you'll be feeling better. The dressings will come off after 1 week, so you will be feeling better after 2 weeks, but you'll still be wearing a supportive bra. I don't know. Is it a lot? Is it hard to pull those things? So after 2 weeks, you'll be able to do stuff. I mean, if you are working in the office of Costa, I mean, I can give you a sick note and I can say light duties if that's helpful. If you're working in the office, I think you'd be able to 2 weeks. You might be able to start driving and things after 2 weeks. But I don't know how much, or can you just do the till maybe? I don't know if you're doing a lot of that. That's going to make it swell because it's going to make your pec, which is just underneath your breast, and you're going to make it swell. So I wouldn't be doing too much of that. Or is that a barmaid? You don't tap, 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 don't you? So yeah, I think if you can do non-barista, if you can do non-barista duties, I can give you a sick note and say no barista duties for 4. So I think it's probably going to be 4 to 6 weeks for the arm stuff, but no arm stuff 2 weeks. So you could go back to the office, or maybe till, or maybe the headset on the drive-through, because they don't actually make the coffee, do they? They just take the order. So if you could just do the headset person, so I could maybe say 2 weeks off, and then 2 weeks on the headset, and then you can go back to barista after 4 weeks. Outline it all on the sick note if you want. So yeah, that's where I am on that, Aimie. After 2 weeks, you can do stuff, but 4 to 6 weeks before you're doing too much with your arms. Right, Emma. I've had my breast implants 12 years. Is there a desperate need to get them replaced after a certain period of time? No, Emma. No. Go, girl. I always offer patients a yearly follow-up, but you don't have to keep coming back. So if you're a patient of mine, you're welcome to come back to see me. But to be quite honest with you, Emma, if you have a problem with the implant, you're probably going to know about it. It's unlikely that the doctor will diagnose it. So you don't have to come. It's not essential to come back for follow-up appointments. And I know a lot of people don't follow up patients with breast implants. And I don't think that's necessarily medically bad, because I think most things will be picked up by the patient. But I just like to keep an eye on patients, and I like them to know that I'm around. So that's why I offer unlimited follow-up for people. But probably the main problem you're going to get at this sort of period, Emma, is capsular contracture, which is hardening of the implant, and it's a very subjective thing. So if you don't go looking. If you don't feel that they're hard, if they haven't got any problems, I would say don't worry, leave it alone. Some people talk about scanning, routine scanning at sometimes after 8 years or 10 years or something. I don't routinely scan my patients, although, as I say, I do offer them a yearly follow-up. There's nothing wrong with routine scanning. So you could, if you wanted to consider scanning, if you're worried about the implants, to check the integrity of them. The only issue I find sometimes with scans is that they can sometimes be sort of not 100%. They can sometimes say suggestive of a rupture or something. And I've seen situations where they've suggested it's a rupture and you change the implants and they're not ruptured, and vice versa when they're saying they're not ruptured and you go in and change the implants and they are ruptured. So the scans aren't 100%. So you got to question if you've got no problems with your implants. The only issue I've got is if you then have a scan and the scan's suggestive of a rupture, you'd be like, oh my God, what do I do? Because do you want to go through surgery with costs and risks and complications? And you haven't got any problems. So that's why personally I don't routinely scan. But yeah, so the answer is no desperate need, Emma. Carry on with your life. See people with them 15, 20 years. They say the same person who had them in the 1960s, the first person ever to have them in, has still got them in. I don't know if that's true. I don't know if she's still alive, but basically she's obviously had them in for many, many years. So it is possible to have them in for many years. So no, don't worry, Emma. Just get on with your life, and if you get problems, then get them looked at. But and obviously look for lumps and swellings and things, as you should be doing anyway. If you've got breasts, regardless of implants, you should be looking for lumps and swellings, because obviously you can have a problem with the breast as well as the implant. But yeah, good. Keep going, Emma. Keep going. Holly, #askJJ. Nice one. Is a mummy makeover healing process longer than having them done separately? Yes, it is. Because mummy makeover is basically a breast and a tummy procedure, and you're basically doubling your risks of complications, basically. So if you have them done separately, if you think, you might have no problem. Oh, how can I explain this? Basically, you're increasing. It's because you've got both of them. No, I'm not. I'm just gonna have a lie down. I'll be back in a minute, right? Okay. Can we just cut that? Can we just do another take on that? Okay. Is a mummy maker #askJJ? Who's that? Sorry. Yeah. Yeah. Sorry. You need me now? Oh, I've got to go. Oh, I've got to go. Sorry, guys. No. Right. Is a mummy makeover healing process longer than having them done separately? Basically, if you have a tummy tuck, let's say your risk of having a wound problem is 1 in 10. It's not. It's less than that. But let's just say it. And if you have a breast lift or something, your risk is 1 in 10. So if you have a mummy makeover, your risk is 2 in 10. So it's sort of like the same as. So do you get me? So it is the same as if you'd had it done separately, because it would be 1 in 10 for the first one and then 1 in 10 for the second one. But it's actually 2 in 10. You're doubling it up. Tumbleweed. So is it more? So does that mean it is more, or isn't more? You could argue it's the same, but you've got the risk at the same time for both. Yeah. Have I made that clear? So it doesn't make you more likely to get a problem in either one of them, but you could get a problem because you're having them both at the same time. You've got more areas to worry about. I thought this would be an easy one. I understand. Right, Holly's posted that she's understand, so we can move on. Thank you, Holly. Thank you. Sorry, I didn't. I think I didn't answer that very well, but anyway, good. Amy, awesome. Thank you. Do you guys offer finance options? I'm on a weight loss journey currently. Then I'd like to book in for a consultation with you. Hashtag askJJ. Hashtag am I doing this right? Amy, look at you bringing new hashtags. Hashtag am I doing this right? In caps. You know what? That could be the hashtag that I could put on every single post of mine when I'm doing this Facebook Live, to be quite honest with you. So the hospitals offer finance options, Amy. So the hospitals, I'm doing a lot of work up in Liverpool, which is a little privately owned hospital. So there's no finance options there. The hospitals that I normally work at around the Midlands, which are the Spire and the BMI hospitals, do offer finance. They do offer 0% for 12 or 10 months. So yes, they do. And it seems to be they're coming back online, the ones around here, but we'll have to wait and see. And so yes, and the reason why the one up in Liverpool doesn't, and also my clinic doesn't, is because, you know what, it's quite hard to beat the high street. They do low, 3% loans and stuff like that on the high street, so it is hard to beat it. But obviously 0% beats it. But the hospitals do that. So anyway, yeah, okay. Next question. Have you ever done? It's going well, I think. I don't know what you think. I think it's going all right, isn't it? Just tripped up with that mummy makeover one, but you can't have everything. Have you ever done / had experience with breast fat transfer? Yes, ma'am, I have. I used to do breast fat transfer almost every week. I used to do it all the time when I worked in the NHS. And the reason being, I was doing breast reconstruction after cancer. So if you're reconstructing a breast, you often have some contour irregularities, some volume discrepancies between the breasts, one bigger, one smaller, dents, things like that. And fat grafting is brilliant. Fat grafting is brilliant because it adds volume. It can add volume in a three-dimensional way. So if you have a bit of a contour irregularity, you can add volume into that contour irregularity, whereas an implant just sort of globally makes the whole breast bigger. But since I've been doing cosmetic breast surgery rather than reconstructive breast surgery, I hardly ever do it. So I have got a lot of experience in it, and I've done hundreds of cases, but I hardly ever do it now, to be honest with you, because, and I love doing it as well. I'd like to say, full disclosure, I absolutely love it. It's a great technique. It's a brilliant technique. Using your own fat, it's brilliant. Complication rate low, longevity, once it's there forever. It's brilliant. The reason I hardly ever do it is because the results are really subtle. And cosmetically, you're usually having to do it to both breasts. With the reconstruction, you're trying to balance out a volume discrepancy between the two. So you can put all the fat in that one breast. Whereas if you're having to split it between two, the results are subtle. The volumes are low in my hands. So in my hands and in my experience, the volumes are low, the results are subtle. You're looking at about 50 to 100 cc's is probably where I'd be going with a fat grafting. If you want cosmetic augmentation, you could easily go 250 cc's, 300 cc's with an implant, which would mean 5 or 6 operations with a fat grafting, and it's expensive. So it is good, and it's a brilliant technique, but it is expensive, and you often have to repeat it. So it's got limitations. So you have to counsel patients about it to make sure that they're aware of that, and therefore hardly ever do it. By the way, anyone who's joined early or joined recently, fat grafting into the breast we're talking about. So I've done a lot of it, but I don't do much now with cosmetic augmentation, because for me, augmenting or enhancing the volume of the breast, implants are still gold standard, the one to beat. I like the concept of fat grafting. I don't like potentially having problems for the future and all the risks you've got with implants. I'd rather not use them if I didn't have to, but I do think they are still the best way to enhance the volume of the breast. and fat grafting is just not there yet, unfortunately, in my view and experience. Can you combine an arm and a thigh lift? An arm and a thigh lift. Can you combine it? Well, can you? Yes. Can you? Should you? That's the question, isn't it? Oh, hi Natty. Hello. Should you? So can you combine an arm and a thigh lift? Answer, yes. Should you? Answer, I don't think you should. No. Personally, I think it's too much to do an arm and thigh lift in one operation. I think it's difficult for surgery. Oh Christ, sorry. It's difficult for surgery. You're prepped arms and thighs. It's all a bit difficult. Thank you for amazing work yesterday. Oh, Natty. Oh, I didn't know that was you. Are you back? You're back. Yeah, long day, eh? Well, maybe not so long for you because but it still was a long day for you. But yeah. So arms. I hope you're okay. Arms and thighs. You're prepped. Your whole body's prepped. You've got to prep the middle bit. You're exposed. So it's big in terms of your exposure for surgery, and also post-op. It's your post-op recovery. Having both arms and both thighs out of action is not great, and I would not recommend it. I think arms and thighs in one go is too much. Personally, can it be done? Yes, it can. I don't think it would be a good thing, and I would probably, if you're coming to see me, I don't know who's asking this question, I would probably advise against it, to be honest with you. I totally understand why you want to get it done in one go. Arms and breast, yeah. Thighs and tummy, yeah, that's a common combination. You're sort of locating the problems in one area. But to have both arms and both legs uncomfortable, I think that's a bit, I don't think that would be great, personally, in my view. Just my view. Natty's feeling great. Big up yourself, Natty. What a player. What a great patient. Rebecca's view. What is the price for liposuction, belly and love handles and boob job? An approximate price, please. Oh, blimey. No idea, Rebecca. Can you email us or direct message me with your email and we'll email you? So just to pick up on the belly liposuction, I tend not to do belly liposuction. The skin doesn't retract well and I don't get good results. Love handles, yes. Belly, no. Belly, I find the best way to contour the belly is a tummy tuck. But I understand if you're thinking liposuction, a tummy tuck is quite a significant step up from liposuction. You might not want to consider that. But I am always a bit reluctant to do belly liposuction because I find that once it's a bit like weight loss. It's the reason people need tummy tucks. You lose the weight, the skin doesn't recoil from the abdomen. It recoils from the hips. That's in your love handles. That responds well to weight loss, but your tummy doesn't. That's why people need tummy tucks. And basically, liposuction is doing the same as what weight loss would do. It's just removing the fat. And my worry is if you're left with redundant skin there, you're not going to be happy. So I would say that a tummy tuck is better, but but certainly, and boob job. Rebecca's view, you got to be a bit more, if you want a price, if you can say like it's a lift or it's implants or a lift and implants or a reduction, because there's lots of different things you can have to your boobs. I guess boob job is traditionally implants, I'm guessing. Is that what people normally consider to be? So yeah. But if you message me or give us a ring, 0121 454 3680. Hello, Staiano Plastic Surgery, how can I help? Then they'll give you a price. I don't know price. I've got no idea. I'll get it wrong, and then you'll say he said that price, and then we'll be in all sorts of trouble if I try and mess with prices. I ain't messing with prices. Got no idea. Not prefer blank that bit out. Blank it out. I want to think about it. Just implants. I have nothing. Just implants. Does anyone know how much implants is? Is it 6,000, 7,000? I'm not sure. See, I've said something now, and they're gonna say it's something, and you're gonna say he said that. I don't know what it is. It's thousands. It's thousands of pounds, several thousand. But they'll help you if you ring them, or as I say, if you direct message me on Instagram or give us your email on Instagram, I will ask them to email you prices of this sort of stuff, or you give us your number, message me your number, and we'll ring you or ring us. That's the best thing. Right. Can you tell us more about twilight sedation, please? Well, twilight sedation is local anesthetic with sedation. So it's not, you're not awake. A lot of people think you are awake, and it is, you're quite sedated. So you're quite like that. And it is a great thing. It's a really good thing, and it's a really good way of doing surgery. We used to not do much of it, to be fair. I used to only do it when people asked for it. I'm still a bit like that, but there was a period where we could only do it under local sedation. So we did ramp up and did a lot more under local sedation. We're back now to having GA facilities. So there's a bit more of a sort of choice, really, whether you have local sedation or a GA. It's not for everybody, and it's not for every procedure. So you don't really, the bigger procedures, so bigger breast reductions, tummy tucks, bigger ops, I'll be a bit like, I don't know, people do it. Well, I have not actually done it on bigger ops, but a bit like, maybe I wouldn't push it. But certainly for things like breast augmentations, it's a great technique. Just done one before I came back here on a patient. And the great thing about it, so there's good and bad, like anything. If anyone tries to tell you something's great, and it's the next big thing, you've got to think, well, why doesn't everyone do it? Why isn't it? So there's good and bad. The great thing about it is the recovery's quicker. People afterwards, they feel much better. They don't, if you've had a general anesthetic, you feel a bit hungover, a bit sick, and a bit, you do feel much better after local anesthetic and sedation. The recovery's a lot quicker. You're up and about. You go home like an hour after the surgery, literally. It's amazing. The recovery's much quicker, and you feel a lot better. And you don't have that general anesthetic to get out of your system. The bad thing about it is that it can be a bit uncomfortable. You can feel bits and bobs. You can feel pushing and pulling. So if you're going to be stressed, if your patient has to be state of mind, have to be up for it, sort of thing. It's about patient selection. If you're a bit anxious and you're a bit worried, no problem. Just have a general. Boom, you're out. Then you're back in the room. It's fine. So it is about patient selection. So it is about choosing the right patient. So you have to be sort of up for it. You have to be game. We don't really want to force you into it if you don't fancy it, because then you're going to get stressed out and not have a good experience. But if you are up for it and you think, and often we usually work in theatres where we can do a general. So if you're feeling uncomfortable, if it doesn't feel right, and you think, oh, you know what, I'm not enjoying this, or if we think, look, you're not enjoying this, it's not good, we can always convert you to a general. You're always set up for a general anyway, so you can be converted to a general, because an anaesthetist has to do the sorry, I'm playing with crystals. The anaesthetist has to do the local sedation anyway, so there's an anaesthetist there anyway, so it's no stress, no hassle for them to convert it to a general. But yeah, twilight sedation for the right sort of operation, breast lifts, smaller breast reductions, breast augmentation, really good procedure, really good technique. I am worn out. Natty, you'll know why I'm worn out. I am worn out. So who's up for a bit of Antiques Road Trip? Hands up. Me. Right. I give the second episode, I believe, 807. If you've got any questions, by all means ask them, because I will be very happy to answer them. But if not, I'm going to go and watch Antiques Road Trip. If there's no other questions, if you have got questions, by all means post them, message me, Facebook me, Instagram me, YouTube me. All right, we're on YouTube, guys. What do you mean you don't know we're on YouTube? For God's sake, get yourself over there and get subscribing. We got 1,000, well, more than 1,000 YouTubers. Jackie, you must have subscribed on YouTube. Come on, tell me. Jackie has been here start to finish. Come on, Jackie, get yourself over. Lowry J22 has just arrived. Get yourself over to Antiques Road Trip 17, channel 17. Let's do this. Come on. Jackie, you've missed the whole first Antiques Road Trip for this. Come on. Have a word with yourself. Honestly. But I very much appreciate your support. Thank you for being there. Right. I don't know, where is that the camera? That's the camera. Right. Good. I am going to check myself out. I don't know about you. I'm going to check myself out. I suggest you do likewise. And please, by all means, message me or get in touch. Lowry J's just enjoying and put loads of heart. What is that heart? How did you get that heart up there? Good God, I didn't know. That's not even an emoji. Anyway, that's awesome. Right, I'm going to check out Facebook. Checking out Facebook. Take it easy. See you next time.